Hey, everybody. Welcome to Tea Talk Tuesdays. So, if you're new, welcome for the first time. So, we may have some repeat people from last week. Last week was our premiere, and this is follow up from that. If you're new, please make sure that you put any questions or comments in the chat box. I'm not sure if you're with Facebook or LinkedIn or on YouTube, but either one, you should be able to make some comments. So this live stream is designed to actually be really interactive. So we're creating a community here for all in healthcare. And the whole idea is for everyone to be able to ask questions and get some free advice. So it's kind of our way of giving back here at Stalking Horse. I think a couple people have joined in already. I can't tell yet who is in. I'm going to give a couple minutes here too to let some folks that I know were maybe running a bit behind to jump in. So just a heads up too, it's where I am. We have like really high grass pollen right now. And I don't know, this is the first year it's been really bad for me. So if my voice goes in and out, it's definitely due to the pollen. So I may have some voice cracks or puffy eyes, but just bear with me. So also, again, if you're new, we even have an email address that's ttalk@stalkinghorsellc.com, where you can actually email us in questions or examples that you would like discussed during a Tea Talk event. And so, again, it's a way to get some free consulting essentially. So remember, ttalk@stalkinghorsellc.com. Feel free to reach out to us. You always have the option also to reach out through social media and our website too. So, oh, hi, Lainey from Florida. Nice to see you back. I think we have a couple of other returning members also. So here in Florida, we again have that really high pollen count right now. It's terrible. Well, I say it's terrible because it's the grass pollen, but everybody else. We've also got upstate New York. We've got Morgan. Hi, Morgan. And also Ricky's back. Very nice to see you guys back again. So with this Tuesday, we are going to go ahead and revisit some topics from last week. I know that the screen share was difficult last week, so a couple of the topics we didn't really get to cover very well. So we're going to make sure we do that tonight. And again, if you have any questions or comments, please go ahead and post them so that we can address them, because that's what this is about. It's not really supposed to be a webinar, right? It's a community for us to share and go back and forth. So that'd be great. So the first topic that we had started with last week was that visit complexity code, the G2211. And I know that a lot of providers have had difficulty with either feeling comfortable documenting it, and then there's some that feel very comfortable with reporting it, but don't really know how to back it up with the documentation. So that has been an interesting topic so far this year. Because January, it kind of exploded because they allowed reporting this code, which you can add on to your evaluation and management level. So many providers have been trying to take advantage of that. And it's, doesn't matter what specialty providers in. It's just for what they call visit complexity. And it really is about relationship development. And I had some links to share. And so on our community page on the YouTube channel, there's a document up there that says Tea Talk Tuesdays references and resources for April 2nd. And since this is a continuation of that, you'll be able to see that document there still. And those have all the links on there that I had wanted to share. So I'm actually going to try to share my screen, and let's see how that goes. I'm going to do this document here. So you'll be able to see. So this is the document that's on our community page. Oh, hi, Sonia. You just joined again from Florida. Nice to see you on there. I wasn't sure if you were going to be able to make it. I know there's some AAPC events going on tonight that some people are joining, and so I wasn't too sure if you were going to make it. So it's great to see you in. It's awesome. So if you go to this document and click on the links for each topic, it's some really good, helpful information. So for the first one, let me just make sure you can see it. Let me pull that back up for you guys. I'm still getting used to this StreamYard platform. It's a little bit different from other screen shares that I've used in the past. I use WebEx a lot. I know some people are like diehard into Zoom or Teams, but I actually really like WebEx. So, and this is why I really like WebEx, because it is not that difficult to share the screen. There we go. So sorry about that, guys. So this MLN Matters article here, this is on the G2211, and it goes over how to properly use the code. And if you aren't already familiar with MLN Matters articles, it's from Medicare. They're fantastic because you know that you're getting, firsthand information, and that it's going to cover like usually about 90 to 95% of what Medicare has put out there. Occasionally they put updates out there that are not on the MLN Matters article, like when they make updates and such, but typically they're really good. So this kind of gives you that effective date of January 1st. It talks about this MLN Matters article was implemented February 19th. So about a month later. And it goes over who's affected by this code. And it goes into actually some examples of how to use it. And the main thing I hear people talk about with this code is really like, how do we document for it? And one of the biggest issues that Medicare has had with this code is giving examples, and they actually state in this document under documentation requirements, they state we haven't required additional documentation. And so I think that most interpret that incorrectly to mean that we don't require any documentation, but it's specific to additional documentation. So they expect that we already would have what needs to be documented within the note is really what that means. They're not requiring anything additional to be there other than what should already be there to support it. So there has to be medical necessity there. And the two examples that they give are listed here. And I know our team, we just found it kind of comical when we went over these examples because the first one is super bizarre. So, they say a patient sees you, their primary care practitioner, for sinus congestion. You may suggest conservative treatment or antibiotics for a sinus infection. You decide on the course of action and the best way to communicate the recommendations to the patient in the visit. How the recommendations are communicated is important in that it not only affects the patient's health outcomes for this visit, but it also can help build an effective and trusting longitudinal relationship between you and the patient. This is key so you can continue to help them meet their primary healthcare needs. So they actually say that the complexity code G2211 is supported here, and that the complexity isn't captured in the condition, it's captured in the relationship building between the provider and the patient. But the funniest thing is that they don't actually give an example of what that documentation should look like. Like they're talking about it, you may suggest conservative treatment. You decide on the course of action and the best way to communicate the recommendations to the patient. The only way we know that, like what recommendations were communicated, how it was communicated, that there was relationship building, is if there's documentation for it. So, this example we felt was not particularly helpful at all. And it's not something that we would have expected to see, because we wouldn't have thought of a patient with sinus congestion kind of qualifying for this. But it's true that if you think about the relationship development aspect, that could be the case. But that documentation is really going to have to show the development of that relationship. And, a lot of providers don't go into detail in the assessment and plan, especially with this type of complaint. They don't typically go into great detail about discussion. So that could be challenging to support in an audit situation. And then when they talk about reviewing, because they're definitely saying audits will be done, they say that these 3 bullets here, that these elements could be used, or these items could be used as supporting documentation for billing it. And of course, the first thing is information included in the medical record or in the claims history for a patient practitioner combination, such as diagnoses. So if they're going to try to show that relationship, like this provider is treating the patient for this specific complex condition, that makes sense, right? Because they'll see the patient coming in on a continual basis for that problem with that practitioner specifically. And then also the practitioner's assessment and plan for the visit. So that's, again, where that key information would be about the relationship development for the patient. Then they say other service codes billed. So in specialty practices, that could be helpful also, because there could be additional services that a patient may need for a particular diagnosis, that they may provide there that could help support that they're treating them for that condition, that serious or complex condition. Now, the second example that they give was a much better example, in my opinion, just from a complexity standpoint with the condition itself. So they use a patient with HIV who's seeing an infectious disease physician. So the patient tells the provider that they've missed several doses of their HIV medication in the last month. And then because that provider is a part of their ongoing care and they've earned the patient's trust, they tell the patient it's important not to miss their medication while making the patient feel comfortable and safe sharing that information. And so the whole point of that example is that if a provider has developed a trusting relationship with their patient, the patient's more likely to tell them the things that they may want to hide otherwise, like, hey, I haven't really been taking my medication. This is why. And that will help the provider to not make a rash decision, such as changing a medication to something that could potentially have more side effects, be more risky for them. So it does help them to manage that patient correctly and I'd say in a more safe manner. Um, and again, just having that trust allows for more open communication. And I think for providers in general to be able to help the patients through things, which also actually relates to the second topic, the social determinants of health. Because I can say that one of the things too is sometimes patients just can't afford their medication. So they'll try to like stretch it out. And so if they buy a prescription um, for 1 month that they really can't afford, they may try taking it like every other day or every couple of days, thinking that they'll be able to stretch it out and it will be as effective. But if the patient is comfortable with the provider, they may be able to share with them that, hey, I really can't afford this medication. And then the provider may be able to, or the office may be able to give them some resources to help them afford that medication. There are programs out there that may be able to help with that. And then also the other like tricky thing is modifier 25. I thought it was so weird when we started talking about it. I don't know about you guys, anybody on this live stream tonight, but I thought it was like really odd. Like they do not want to pay for the G2211 if you report the E&M with a modifier 25. Like they don't want to cover it at all, which I can understand to a certain degree. But at the same time, like if a patient comes in and, like this first patient that's coming into their primary care practitioner, so they have an example that they give. And let's say they go through all this that they give in that example, and then the provider also realizes, oh, hey, you're due for your flu shot. And so they have to put a 25 modifier on the E&M. It's just sort of bizarre to me that then that excludes them from being able to report the G2211. I just think that that's really weird. It's kind of like some of the other codes, like chronic care management wasn't allowed to be reported in the same month as TCM. That's a whole nother topic, but it just is bizarre. I'm kind of thinking that might change down the line, but we'll see. You never know. There's also another link that I shared. See if I can get that one to pop up here. And so this link I felt was important to share too, because I really like this site. Um, I use this site a lot for different topics, and they have some really good information on everything like G2211, social determinants of health. They have good information on chronic care management, other E&M questions. They just are really, really good. So the AAFP. So if you need another site that's pretty reputable, I would definitely recommend them. And so this really goes into some good details also about G2211 and when to use it, how to start billing for it, and some other exclusive resources. So they do have like membership-based information there. That is one thing. Like they give you so much information, and then after that, you have to possibly become a member to access certain things, but that's okay. Also, we do have a webinar on our products page of our website, and that webinar on G2211 is pretty darn good, I must say. I really enjoyed putting that one together. So if you have any more questions about that, it might be a good idea to check that out, or you can feel free to ask here in the chat or the comments, and then you get the advice for free. But we do have a few webinars on there, and actually we just put one out yesterday for modifier 25, and it's free. So it is free. You can actually view it on our YouTube channel, or you can go to our website's product page, and then you can download the webinar with some PDF documents that we put together to go with it. And that's completely free. So we're trying to put as many resources out there, either at a really reasonable discounted price or for free when we can. So we did put that one out there for free. And of course, we always have Tea Talk Tuesday. So that's there. Yeah, it looks like Brandon may have joined. So welcome, Brandon. I don't see you in the chat yet, but I see you were welcomed by some of the other members. So welcome. All right, I'm going to jump into the social determinants of health. And so let me pull up a resource on that. If you guys don't know much about the social determinants of health, I highly recommend you look into it because it's sort of a hidden gem and it can really make a difference in your practice for your patients. And there's also reimbursement attached to it too now because the whole concept has been out for quite a while. But I think that the government realizes that in order to really push something, even though it improves care, there needs to be some kind of reimbursement for it because it does take up administrative time and provider time. So there should be compensation for it. But what I found interesting was the beginning of this year when everybody was talking about the physician fee schedule final rule that I've just pulled up here, everybody was like super focused on the G2211 because it was called out by name in the within here within this final rule. So that's right here, G2211. But everybody seemed to skip over the social determinants of health section that's up here. And what's interesting is if you are performing or you're going to perform risk assessments for social determinants of health, it actually is a higher paid code and service that you can add on than the G2211, which was insane. So it's just crazy that nobody's really been talking about it yet. Now, the implementation date for claims is July 1st. So now is the time to get the practice set up to start actually performing the service. So many offices, it's going to take time to get a process and procedure in place for patients. But they mentioned in the final rule here that they are finalizing coding and payment for social determinants of health risk assessments to recognize when practitioners spend time and resources addressing social determinants of health that may be impacting their ability to treat patient. So I gave an example of that earlier. So if you're really unfamiliar with social determinants of health, an example would be that patient who isn't taking their medications properly because they can't afford it. So their financial strain would basically be impacting their health care. So there's all kinds of things that are in our social lives or in our environment that can impact our health, right? So obviously financial instability, housing insecurity, food insecurity, even issues like having access to clean drinking water and things like that obviously really impacts your health. What's around you, what's available around you for resources really can impact your health. So they've really recognized that. And there's like some insane amount of connection between health outcomes and social determinants of health, which I think also then closely connects to mental health as well. And so I think the two largest provider groups that are going to be key in working with patients with these risk assessments would be primary care and behavioral health. It's not limited, but I could imagine those being the two largest groups that would really be performing these risk assessments, and that it's going to impact those practices the most, or at least it should. And then, so many say, well, how and when can we provide that risk assessment? So really, it can be provided like during an annual wellness visit. And First Coast Service Options, this is a Medicare administrative contractor or a MAC, right? So they are actually the ones over the state of Florida. So if you have a patient who has Medicare that's in the state of Florida, you practice in the state of Florida, the claims go through First Coast Service Options. But they actually put out some information regarding annual wellness visits, and they included a section on what's new. And they talk about the social determinants of health and that code, which is G0136. So they're saying if you perform that risk assessment during an annual wellness visit, you can attach modifier 33 to the G0136, and that notifies Medicare or First Coast as they process the claim that the copayment and deductible should be waived when that risk assessment is performed with that modifier. So it's the patient doesn't have to pay for their copayment and deductible when you perform it during the annual wellness visit, as long as you attach that modifier 33. Now, with that being said, they're saying that the G0136 is covered once a year with the copayment and deductible waived. I actually did some additional research from last week and found that Medicare is stating that they're going to pay for this risk assessment to be completed twice a year. But obviously, once with the annual wellness, you can only do the annual wellness like one time a year anyway. So that makes sense. So one time where the copayment and the deductible will be waived, and then it can be performed again. So 2 times a year. So once every 6 months, which does make sense because, you know, patients' situation can change even from month to month, right? So we would want to do it more than once a year. There's also a screening tool that's available that I wanted to share because I think it's a great tool. It's very easy, clean, and again, it's the American Academy of Family Physicians, so they have a pretty good site here. So it goes over the different sections like housing, food, transportation, utilities, childcare, employment, education, finances, personal safety. So this has a lot of the questions. This is essentially the risk assessment that you could perform. And when you perform this, if something comes back positive on it, the provider would need to be documenting that in their record. And then the appropriate recommendations would need to be documented and performed. So obviously, if a patient is talking to you about, let's say, a housing need, suppose that they are at risk for homelessness, it would be expected that then you would provide them with some resources and some information to assist them with that. So it may sound harder than it actually is, because I myself was like, oh gosh, you know, how do you do that? Like if I was running the practice, how would I get that information? But honestly, if you just Google resources in your area, a lot will come up. I tried it myself for our area. And then also like reaching out to local like churches, Salvation Army, food pantries, and getting a list together that you can provide contact information for patients, and even developing relationships with some of the lead people at these organizations would be super helpful, so you can connect your patients that are in need with those people so that they can fill out, because a lot of times there's information they need to fill out, like applications and whatnot for assistance. So connecting them with the right person would be what you would need to do, and then following up with them. And again, this can really make a difference in the community. I don't know about where all of you are located, but I know here we've definitely seen a huge increase in homelessness, and it's pretty wild. I also frequent Vegas, Las Vegas. I have family there, and so when I go there, I've seen a lot of homelessness and an increase in that as well. So it's definitely a big crisis. Then we had all the stuff with COVID going on, and we actually have seen an uptick, I think, since after that, people not being able to afford their rent and ended up being kicked out. And so, yeah, I see Morgan just shared that she's seeing it there too, which is in New York. So I can imagine it's just going to be everywhere. And there's some statistics out there about it as well. And again, this is another topic where we do have a webinar available on our website. So if you need some more like in-depth information on the social determinants of health and how it might benefit your practice, or some information on actually implementing it, I highly recommend taking a look at that webinar. So thanks, Morgan, for sharing that. I know, again, it's just getting crazy out there. And then Ricky commented, yes, Vegas is bad. And it is. It is bad. I mean, there's always been a homelessness issue there, but it's definitely increased since like prior years visiting. It's just worse now. So, yeah. I think I can now jump into risk adjustment. So I don't know if we have anybody here that is in risk adjustment. I know last week we had a couple of people that were really into risk adjustment. But one thing that I thought was interesting that nobody really talks about too much is the audits on risk adjustment. So a lot of organizations get into it, and from the provider level, don't necessarily think about the like bigger picture and what's the whole process for auditing. You know it exists, right? But don't really think about what actually goes on in the background. So I try to check out the OIG's work plan, the Office of Inspector General. I try to check out the work plan a couple times a year just to see what's on their radar, what updates they do. And that's kind of how we learn, right? So after audits are performed, and then we can take a look back and see what the performance was and what the findings were. That helps us to improve what we're reviewing, or helps us give advice to providers on documentation, like what areas in general around the nation we're kind of lacking and what we can do to improve that. So they actually tell us like what they're looking at. And I just, again, find that hysterical because everybody always thinks like it's sort of a surprise, but not from the government. It's like planned out. Like they truly plan out exactly what they're going to look at, and they tell us like, hey, this is what we're digging into and this is why. So if you've never looked before, that first link is just to the work plan. And so it just goes over what the work plan is, how they plan their work, and gives some details on that. And then what was interesting is when looking at the work plan, I saw a lot of information this year about risk adjustment. So when you dig into the work plan, they actually will have a part of their site that goes over the active work plan items. So this is where what I was telling you, like they'll literally tell you exactly what they're going to audit and what they're looking for. So even if you're not into risk adjustment, whatever you're into, this work plan is important for you to take a look at, or somebody in your practice to take a look at, to see, hey, are we performing services that are on this hit list? I know last year behavioral health was on there, and I actually know a few practices that got hit with audits on it. And so that's been interesting to kind of see play out, and waiting for more information on those results. But they definitely follow through with what they say. And if for some reason they cancel an audit, they announce it on the work plan as well. So one of the items that they listed is Medicare Part C audits of documentation supporting specific diagnosis codes. So again, this is it in relation to risk adjustment. And they even state in here that Medicare estimates that 9.5% of payments to Medicare Advantage organizations are improper, mainly due to unsupported diagnoses submitted by the MA organizations. So they're letting you know, again, they're telling you why. Like, based on our statistics, we estimate that 9.5% of payments are improper. So they want to recoup that money, they want it back. I don't know if you guys are aware, but like, it was last year, I believe, that Humana got hit really hard, like owing millions back to Medicare for improper diagnoses and risk adjustment. So they're serious about these audits, and they are working on narrowing down exactly what conditions they want to look at. So they state here it's specific diagnosis codes. So that I thought was very interesting too. So they have actuaries that work with them, and they just analyze data constantly. So they're going to be able to come up with some information on these diagnoses and which ones are most likely reported incorrectly or improperly. And so when I did some more looking on the OIG's site in relation to risk adjustment, I saw that they went into more detail of that. They're doing audits of Medicare Part C health risk assessment diagnosis codes. So there's risk assessments that are performed, and funny enough, we just talked about one, right? We talked about a social determinants of health risk assessment. So a risk assessment in itself is designed to uh, help providers know if a patient is at risk for something. It doesn't necessarily mean that they have it. It just means, are they at risk for it? So without having to go any further, I kind of just thought to myself, this is probably going to be due to the fact that some diagnoses were probably reported based on a risk assessment by itself. Like, so the diagnosis was there on the risk assessment, but yet there was probably no other services related to that diagnosis within that year. So when we talk about risk adjustment, really what they're doing is they're saying, we want to know what conditions this patient has that are impacting them through the year and into that's going to be impactful next year. So they want to be able to estimate cost of care through the diagnosis codes that are reported. So if you have a group of patients that you see in your practice, right? If they look at all of the diagnoses that you report on those patients, they have those actuaries kind of put together some information where they can estimate the cost of care for the next year based on what you reported this year. So that's what they're looking to do, but they want that information to be accurate. There's some conditions that won't impact future care. So, for example, if I find out that I have a bad gallbladder or appendicitis or something like that, and I go and I have that treated, and let's say I have a cholecystectomy or an appendectomy, so that condition is then gone, it's removed, right? So I shouldn't be impacted the next year. Like, it shouldn't increase cost next year. Certainly would increase cost in the current year because going to have surgery, but the next year it won't help predict cost for that. So the same thing with these risk assessments. If there's a diagnosis that comes up on a risk assessment, there should be evidence then of that diagnosis being treated, because if it's not impacting the cost or impacting their care, then it has no place in risk adjustment, technically speaking. So that sort of became obvious to me just from the experience that I have, that that's probably where they were going with it. And so then I wasn't surprised when I saw this next bit of information. They actually came out and said Medicare Advantage payments generated by health risk assessments. So through their actuaries, they're able to identify when a diagnosis code was reported from a health risk assessment and then not reported anywhere else. And so, oh, this is a good one from Lainey. So, like COPD, exactly like COPD. So, if a risk assessment is done, and let's say that it comes back that, COPD, this patient has or may have COPD, but yet there's no other treatment or evidence of that condition being monitored through that year, yeah, that would be a great example. And COPD is a chronic condition that should, just by its nature, impact the cost of care, increase the cost of care for a patient. And yes, because it would be ongoing care. Correct. Yes, that is correct. So it'll be ongoing care. So another one would be like diabetes, right? Or some mental health disorders like schizophrenia, um, or bipolar disorder. So those conditions that are typically more long term, even heart failure. So there's obviously a lot of examples out there, but they want to make sure that everybody's being fair and honest about the use of these codes, that they are accurate and that they are being managed through the year so that the prediction that they have for cost is correct. Because once they get that predicted cost, they actually Medicare actually gives payments to the Medicare Advantage plans or even ACOs to manage those patients. So payments are based on those diagnoses that are reported. So they calculate the expected cost, and that's what their payment is based on. So that's the difference between like having a risk contract or risk adjustment or just the traditional fee for service. Because traditional fee for service, provider does an office visit, they bill the CPT code and the diagnosis and whatnot, and then they're paid like a per service, right? So again, fee for service. But with risk adjustment, they look at the health of a population and they determine payment based on the health of that population. So pretty interesting stuff. And they also had one more topic related to risk adjustment and audits of Medicare Part C unlinked chart review diagnosis codes. So let me pull that one over here too for you to see. So sometimes there's reviews that take place of providers' documentation from the health plan, and they'll review documentation and then they may submit this information, additional diagnoses, to Medicare without a specific date of service listed. And to me, that's always like a bit of a red flag because just coming from the auditing side and provider documentation side, like you always want to have that specific date of service to back up that condition. But being that they've allowed this type of reporting in the past, they're going to do audits specific to those diagnoses where they don't have like a specific data service that was attached to it. So they're going to be reviewing and seeing if they can determine that that diagnosis was actually accurate or not. So that's going to be also interesting to find out what the results of that are. I'm thinking that they may uncover some more improper payments from that side of it. And the health plans, though, a lot of them hire tons of risk adjustment coders for this reason, to try to help them pass these audits from Medicare, but also ensure that they are reporting everything that that patient has because they want to have the money to manage the patients. So many years ago, there wasn't even this Medicare Advantage situation. Like there was just Medicare and then Medicaid and then just like commercial plans. But if you think about it, there's so many people in this nation, in the United States, that have Medicare. It's almost impossible for Medicare themselves to like manage all of this information. And so the insurance companies, those commercial insurance companies, were like, hey, Medicare, hey, government, like we will take a portion of your patients and we'll offer them a plan under us. We're going to call it Medicare Advantage. And we're going to offer them some additional benefits that you don't, But to join our plan, we're going to offer them some additional benefits like prescription drug coverage, or special programs for people with diabetes or heart disease or COPD. And we're going to get people to sign up, and they're going to have us as their plan. We'll manage them, but we just need you to pay us, every year for managing those patients. And so again, that's where these MA plans were born from. And then that's how they report. So they're reporting all of those diagnosis codes that are reported in the year that would impact payment for the next year, or impact cost for the next year. And then Medicare does their calculations, and they determine what the payment will be to that MA plan for caring for that patient population. And so patients make the choice as to whether they are going to join that MA plan or not. So we've got another question here. Let's see. So is it just Medicare that performs these audits, or other insurance carriers as well? Well, that's a great question. So the Office of Inspector General performs these audits through Medicare and Health and Human Services. So Medicare does do them, but the other insurance companies, so let's say that you have a Medicare Advantage plan through Blue Cross Blue Shield, right? They will perform their own audits to try to stay in compliance with Medicare, because they want to make sure that whatever they're reporting in is accurate, so that they don't get a request back from Medicare to repay money. So exactly what I mentioned happened last year to Humana, where Medicare is saying, hey, you owe us millions back because we paid you improperly because you sent us bad information. So Humana, Blue Cross, Cigna, Aetna, whoever has a Medicare Advantage plan, these carriers, they should have a process in place internally where they're also performing audits internally on themselves, as well as on the providers that they pay. So they're in-network providers. They're going to review their documentation and ensure that what's being reported is correct as much as they can. So they put in their own compliance process to try to help them avoid any potential negative impacts or improper payments from Medicare. Then what also happened was there were groups of physicians that would come together, and they'd form an ACO, or an accountable care organization. And so when these groups of providers came together, they said, hey, Medicare, not only the insurance companies can manage those patients, but we're capable of doing it too. We've come together and we've created this accountable care organization. We want you to assign us some patients to take care of, and we'll report the information to you on our claims, just like the insurance companies do. And then you can pay us directly for managing those patients. And so we haven't seen a whole lot yet in the data come out about the OIG auditing the ACOs, but they surely can do it, and they can be included in these audits. So it's also important for those ACOs to have a process in place for reviewing their coding, making sure that it's accurate and appropriate as it gets billed out to Medicare. And also make sure that it's complete and specific, because if they're also underreporting, so if the patients are actually more sick than what they are reporting, that could also impact them negatively, because they then will not have the funding to keep going because they won't be getting paid appropriately. So there's also the chance of underpayment, right? So that's where they really start to find out that this coding stuff is actually super important. And that coding is dependent on their documentation. So they really need to get that education for how risk adjustment works and what's appropriate for coding, how things should be documented appropriately and reported, and having that like a compliance plan in place to ensure that they have those safeguards to not report inappropriately, as well as reporting everything that needs to be out there to make sure that they are getting paid for what the work that they're doing and for their patient population. So again, I just want to remind you guys that if you have any questions that you want to send in, email us here at ttalk@stalkinghorsellc.com, and we'll be sure to include your questions in upcoming episodes of Tea Talk. So it's every Tuesday at 7 that we will be on. And I'm going to go ahead and stop the screen share now. Oh, wow. I was able to do it pretty quickly this time. I'm getting better at this. So I think that's going to just about wrap up those topics. If you guys have questions or want to see a specific topic for next week, please let us know. If not, you'll be at my mercy. It will be whatever our team chooses. And coming up here pretty soon, we hope to have some more of the Stalking Horse team on as well. And we've got a really great team here, I must say. We're pretty lucky to have a nice group of people. And they all bring something interesting to the table too. So if you also need any help with audits or revenue cycle management, just reach out to us. There's our website. We're also on Facebook, Instagram, LinkedIn, and of course our YouTube channel and our website. So feel free to contact us with any questions or concerns that you might have. And we're hoping to grow our community here. So make sure you tell your friends and anybody in healthcare about Tea Talk so that we can keep it going and help you guys get some free, good information for the future and for your practice. So with that being said, I hope you guys have a great rest of your evening, and we'll see you again next week. Just remember, you heard it straight from the horse's mouth. Thank you guys so much for joining.